Good morning, all, and a very warm welcome to today's CME commemorating the World Cancer Day. We have topics lined up relating to oral cancer. And before starting my topic, I would like to extend my sincere thanks and warm regards to our chairman, beloved chairman, Dr. Jacob Raja, the principal, Rajas Dental College, and the esteemed faculty, heads of all OO departments, instrumental in setting this up. So, thanks for the opportunity to be amongst you, enthusiastic students and postgraduates, as we say at the dais. My topic will be on oral potentially malignant disorders, current evidence-based practice. So, I am Dr. Sivaram, and let's start. Starting with the basics, we are aware of these terms, the precancerous lesion, which refers to any morphologically altered tissue where oral cancer is more likely to occur than apparently normal tissue. And the precancerous condition is a generalized state associated with significantly increased risk of cancer. And together, these two are clubbed under a common heading as potentially malignant disorders. Where there was a lot of ambiguity and variation with regards to the terminology, all these were solved in a 2020 consensus report published in collaboration with the WHO on the nomenclature and classification of oral potentially malignant disorders. So now there is no ambiguity. We are going to base our discussion on these topics only. And they have extended a new definition as oral potentially malignant disorders are any oral mucosal abnormality. You just look at the highlight on this. It's a mucosal abnormality that is associated with a statistically increased risk of developing oral cancer. So this definition has two integral components. That is, it has to be an abnormality. It need not be a specific lesion or a state, but whatever a condition that causes a mucosal abnormality, and that ultimately leads to increased incidence of oral cancer. This definition excludes patients who already have frank carcinoma, that is, lesions or mucosal abnormalities that are deeply ulcerated, exophytic, or indurated. So that means it is not just limited to the mucosa, it is extending beyond. So these are essentially ruled out. So let's see what are all included. Conventionally, we are all familiar with leukoplakia, its variants, proliferative varicose leukoplakia, erythroplakia, and conditions like oral submucous fibrosis, lichen planus, rarer lesions like actinic cheilitis or actinic keratosis, commonly involves the lips, palatal lesions seen in reverse smoking, oral lupus erythematosus, and generalized conditions like dyskeratosis congenita. 2020, we had two new additions, which are oral lichenoid lesion and oral graft versus host disease. Now let's put these in some order. So that will be lesions are leukoplakia, PVL, erythroplakia, oral lichenoid lesion, actinic cheilitis, and palatal lesions, and conditions like oral submucous fibrosis, oral lichen planus, lupus erythematosus, dyskeratosis congenita, and oral graft versus host disease seen specifically after allogenic bone marrow transplantation. Let's delve a little deeper and ask a few questions. Why should they be treated? Why should they be diagnosed and treated? Any takers for this question? It's pretty straightforward. We said all these oral pre-malignant disorders, they lead ultimately to cancer, or they have a higher predilection for developing cancer. So it is for this very reason that we have to treat them, diagnose them, and treat them at the right moment with the right interventions. So we may ask, what is the risk of malignant transformation? So, what lesions should be treated aggressively, where a wait and watch or a slightly less aggressive option may be considered. Different people may come up with different estimates, but then we had a recent meta-analysis, 2019 published, Potentially Malignant Disorders of the Oral Cavity and Oral Dysplasia, a systemic review and meta-analysis that gives us definitive data. So, if you look at the lesion as a group, it is the proliferative varicose leukoplakia that has a cumulative risk close to 50% and a risk of close to 10% per year. So this has to be treated with the highest priority. Leukoplakia has somewhere about 8.6% and an annual risk of malignant transformation about 1.56%. So put together overall it is about 7.9% cumulative risk, and you can notice lichen planus is though there were doubts whether it is actually a pre-malignant condition because the risk in various groups, various estimates was found to be very variable, there is a definitive risk of about 1.4 cumulative risk. So that is also considered as a definitive oral pre-cancerous condition. So these oral potentially malignant disorders may exhibit a wide range of clinical features. They can involve any site, and they can be unifocal, multifocal, defined, irregular. They can be white, they can be red, or they can be mixed white and red. They can be plaque, they can be smooth, they can be atrophic, they can be limited or geographic, and specifically certain conditions can also extend to other extraoral sites, pharynx, larynx, and also genitalia, where due to shared etiology, maybe tobacco related, maybe viral related, there can be similar lesions. And it is of note that some leukoplakias may exhibit some ulceration due to abrasion. So we'll see quickly a spectrum of diseases, some of these lesions. Leukoplakia can be as simple as this small or very homogeneous thin leukoplakias to very thick and diffuse leukoplakias, plaque-like, and can be very varied with areas of ulceration. So of these, you can already see areas of this can be at the other end of the spectrum where there may be already a focus of invasive carcinoma. So also, this is an area of verrucous leukoplakia. And these speckled or non-homogeneous leukoplakia. The other classification that we currently employ is of homogeneous versus non-homogeneous leukoplakia. Erythroplakia is much rarer, but where it is characterized to be completely red, devoid of white areas. This is said to be due to the absence of keratin in the surface epithelium. Not all white plaques, you can see some whitish, thin leukoplakia-like areas, but not all white lesions necessarily are leukoplakic and need a biopsy. So this is where we need to look at the definition of a leukoplakia. This is an innocuous leukodema where just stretch, it is differentiated just by stretch. Stretching of this leads to disappearance of the lesion. One can look at just a workup or an approach to oral white lesions. So they can be congenital, they can be acquired. So the congenital ones will be a sponge nevus. They are seen in diskeratosis congenita and the leukodema, which is an innocuous lesion. If the important question, can it be scraped off? So superficial oral lesions, candidal lesions, and pseudomembranous lesions, they are usually able to be scraped off and superficial. Interesting, Marciato, that is bacorum, so that is habitual biting of the cheek or the buccal mucosa, that also comes under this. And if it cannot be scraped off, then they are likely to be a much more serious condition. So these all lesions need to be further evaluated. So how are they diagnosed? We are seeing the entire spectrum of oral potentially malignant disorders in one go, and we are putting this general question: how would you diagnose? Obviously, history and clinical examination. That is how it all starts. So we look at for risk factors. We look at for the age-old dictum, nothing like a good piece of clinical examination and history taking. Ultimately, we would be making this diagnosis by a biopsy. So one of the important questions is to ask which lesions need a biopsy, which need a little follow-up clinically. We also have other modes of evaluation, but at the outset, let's understand that leukoplakia and erythroplakia and all these mucosal abnormalities that we describe are clinical descriptors, and they may or may not correlate with the histopathologic findings. This is very important to understand, that the morphological or clinical appearance of a lesion does not necessarily correlate with the dysplasia that you see. Though all the white lesions, within the spectrum of white lesions, the amount of cellular changes that you see are very varied. So naked examination does not correlate with the pathology findings. So the pathology report should state clearly the grade, the presence or absence, and also the grade of the epithelium. Dysplasia. So obviously, when presented with a very simple lesion, it's very easy to target your biopsy. If at all you want to do it, you do it on a. Whereas in inhomogeneous areas, it is recommended to primarily direct the biopsies in the red areas and also another one, so that when there is an inhomogeneous or geographic sort of an entity, you do take more than one biopsy. So there are various techniques available. You should be all familiar with the newer optical imaging advances, Visilite, and the various stainings methods, Toledan blue, and oral cytology. The advantages of all these is that they are much simpler, they are less painful, and probably faster, and they can be done in the outpatient setting. Newer methods, they're biomarker based, are coming up. But let's see what is the data that we have whether they are ready for clinical practice and day-to-day application yet. So, a recent Cochrane review which looked at this, looking at all the available evidence, looks at the role of diagnostic tests for oral cancer and potentially malignant disorders when there is a clinically evident lesion. So it can be just summarized as one. None of the adjunctive tests, so whatever we described as the vital staining, whereas the newer imaging modalities or oral cytology, all these are collectively the adjunctive tests. They cannot replace the current gold standard, which is a surgical biopsy, followed by meticulous histopathological examination. So all this, where is the role of this? Maybe so we can summarize in one way. A gold standard remains to be a biopsy, and the only question remains which lesions need a biopsy. Well-defined lesions which are clinically aggressive and warranted to be mandated to be risky, which fall under our defined lesions, they need a biopsy. So when can we do or not do a biopsy? So that when there is a frankly suspicious malignancy and when there are high-risk clinical features. We had already said that obviously ulcerated and obviously indurated or exophytic will anyway be doing a biopsy, and all these are considered high-risk clinical features. And also any lesion that is heterogeneous and reasonably large in size, they all need a biopsy. And the bottom line of the bottom take-home message is like any suspicious lesion, do a biopsy. The presence of a lesion in the oral cavity is abnormal. So that means what all lesions that we can do away with a biopsy or where we can safely observe. Oral cytology in this area may help us when low-risk clinical conditions. We may either choose to observe or can do cytologic assessment in the form of a brush. The role of it is clearly there is no evidence for it, neither there is evidence against it. So for low risk conditions, a biopsy may be an optional one, whereas a cytology or some observation may be advised. In either case, all these patients need to be kept under follow-up. Why? In reality, the 5-year survival, it is one of the worst cancers that possibly a human can get. With a 5-year survival, only about 40% are put together, be it for early and it often bewilders all oncologists. Why a lesion which is in an anatomical area which is so easily accessible has a dismal prognosis and survival, and over a large period of time, despite advances in various forms of medical sciences, the treatment, we are adding more and more armamentarium, more chemotherapy and radiation coming, surgery is getting advanced, but still the overall survival has not improved. So that has flummoxed oncologists for quite a long while now. And also the sad part is that the incidence of these oral cancers is also seemingly on the increasing trend, seeming to rise. So especially in young people and also in women. And there is a newer spectrum of HPV related cancers which also come into the mix. So why is this phenomena? Why do we observe this? Why has the prognosis not changed or doesn't seem to be improving? So, well, that is still open for. So probably what we can say is, despite the easily accessible site for examination, and there is no definite screening modality for cancer, for oral cancer, even when there is high risk behavior or when there is high risk clinical pre-malignant lesions. There is no approved or standardized screening program. This could be one of the reasons why cases continue to be diagnosed late and consequently have poorer survival outcome. Another reason could be the overall field change. That is, you may be diagnosing one cancer, but ultimately the phenomena of field cancerization is so characteristic of tobacco-related cancers and in the oral and oropharynx that there is always a second cancer or a third cancer lurking, and ultimately that compromises when there is a collective failure in the field. So the entire field becomes unstable and newer cancers can pop up. So this could be one reason why the dentist has an integral role in management and definitely the prevention and early diagnosis of oral cancer. So one would assume that every patient who is walking into a dental department provides himself or submits himself or lends himself for opportunistic screening for oral cancer and oral pre-malignant lesion. So, but this assumption has an interesting twist in the form of Hart's inverse care law. So this is something, a concept that students should know and should find it rather interesting. Let's see more about it. The prevalence of oral pre-malignant disorders in the general population is much higher in the pop. So you look at it's the prevalence that is much higher. So they are very common. Whereas compared to the number of new cancers, the number of that is the incidence of squamous cell carcinoma, the prevalence of pre-malignant or potentially malignant disorders is much higher. So whenever a patient with OPMD presents to the OPD, he or she may not have such a high risk. The overall ultimate risk of transformation may be low, is low compared to the prevalence. So it has not just, it's just a hypothesis that overall it's been proven in many published studies, especially from the UK. We had two recent studies saying that patients who present to the OPD are less likely to have a progression. So that means the ones who have low risk OPMDs are the ones, because of the increased prevalence and also the slow nature of it, a dentist is likely to encounter a lower grade lesion with a lower risk of malignant transformation in practice more than the real serious ones and aggressive ones which progress faster and have a malignant transformation earlier. Nevertheless, it hurts no one to make an early diagnosis, and to make an early diagnosis we need to have a higher index of suspicion and awareness in general. So all the clinicians who are at the front line are to be sensitized and be aware that the entire spectrum of tobacco related diseases and the oral potentially malignant disorders are a reality. I would like to just say that not just look at the oral cavity as the 7 subsites as described by AJCC. Description of all these clinical lesions have to be a little more meticulous, maybe preferably with sequential photographs, clinical photographs, nothing like it. And even for clinical documentation, I found this a little more detailed subsite descriptors to be relevant and interesting. So finally, we would do well to remember this interesting adage: a stitch in time can often save a life. So never hesitate to consider a biopsy. At the most, you will just take a stitch, and it is a local procedure done under local anesthesia. But a timely biopsy can make an early diagnosis, and that can make all the difference in the world to the patient when it comes to further treatment decisions. Because as my fellow speakers will outline to you later, as resection gets complex, the chance of survival comes down, and with every passing stage, the reconstruction becomes more and more tricky, and overall the patient final outcome is not going to be that good. So please do remember that an early biopsy. Now, I have not elaborated very specifically. I have not delved into the management of any of these lesions, nor the various other innovative approaches in the diagnosis of management, because we have seen that the evidence also supports only a gold standard, a biopsy. The only question remains when to do a biopsy and which all patients can be evaluated. That will still be dictated by a meticulous clinical judgment. And when in doubt, this is very important, when in doubt, do a biopsy. When in doubt, refer a lesion for further evaluation. You do not ever send a patient home reassuring and say come after 6 months, because all these mucosal lesions and all cancers in general and the leukoplakia are likely to be painless lesions. So the patient, especially if reassured, he doesn't have any symptoms until late in the disease stage, that the patient is not going to be getting symptoms. So never send a patient back without a biopsy or evaluation or a referral. So that, my dear friends, is the take-home message for today. And this message is definitely based by evidence, and we don't need any hi-fi or recent molecular markers or bioprofiling or AI-based analysis. All that you need is age-old clinical judgment and a gold standard surgical biopsy. Thank you.